welcome to today's webinar, The Path to Adopting a Successful Alternative Payment Model. I'm Cassie Yazzo, Product Marketing Director here at Cotiviti. Thank you so much for joining us today. Before we get started, I want to quickly run through some housekeeping items for today's webinar. First, you can resize all the windows you currently see on your screen, including the slides and presenter video. At the bottom, you'll see our Ask a Question box, which you can use to submit questions at any point for our speakers. I'd encourage you to submit your questions throughout the presentation rather than waiting until the end to ensure we can get to your question today during the Q&A. At left, you'll find additional resources, including a link to our Network Intelligence Solution fact sheet, as well as some additional resources. Click the image at the bottom right to watch an on-demand walkthrough of Network Intelligence, a solution that supports many of the initiatives we'll discuss today, or you may click Request a Demo to set up a personalized conversation. And click the thumbs up icon to use reactions throughout the presentation to tell us what you think. With that, let me introduce our speakers. As AVP, Network and Value-Based Solutions, Ryan Melander is responsible for directing the overall development, management, and implementation of Medicare Advantage, network, and value-based care strategies, and ensuring delivery of a best-in-class solution. Ryan is also responsible for a team of analysts and consultants who work with clients to uncover insights using Cotiviti's network intelligence. These insights enable healthcare organizations to make decisions that deliver improved health outcomes, health economics, and increased patient and provider satisfaction. Bringing more than 20 years of healthcare experience to her role, Mary Srinivas is responsible for leading the consulting relationships for our clients using Cotiviti's network intelligence solution, developing insightful recommendations and solutions to meet client needs for understanding value-based performance. She also works to enhance cross-solution use of Cotiviti products. And now, let me turn it over to our speakers to kick things off.
Hey, good afternoon, everyone. So what we're going to be talking about and learning today are really about alternative payment models and the path to a successful adoption of one. And so starting with what is an alternative payment model? An APM is a payment approach that gives added incentive payments to provide high quality and cost-efficient care. So as I mentioned, we'll discuss APM development, including the reimbursement landscape as it existed in the past, as it exists today, and what it might look like in the future, the components of a well-designed alternative payment model for successful adoption and outcomes, and best practices for effective interactions between payers and providers to support APM success. So to begin, it's really important to understand the historical reimbursement landscape before we start talking about where we are headed with these alternative payment models. And so the first thing that we're going to talk about is really just a simplified version of the health insurance flow. The health plan industry comprises a number of different participants, and they all have their own incentives and their own motivations. And so if we start over on the left over here, we can see really our members. So we have our individuals that are under 65 and over 65 plus, and we also have our group members, and these can be employees, students, etc. Those members pay copays, deductibles, and have co-insurance pays that go to the providers. And those providers deliver healthcare services in return. The providers receive contracted payment from health plans and government payers, which also receive individual monthly premiums from those members. These health plans can be publicly traded, they can be not-for-profit, they can be Medicare, they can be Medicaid. Health plans also have employers that they tend to contract with as well. Employers can be small, medium, large, or national. And so fully insured employers will actually provide monthly premiums and an employer share the premiums to those health plans. Self-insured employers actually are bearing the risk on their own from those individuals and group members that may be a part of their plan. When we talk about the growth of government programs, looking at Medicare Advantage is really the first place that we want to start. So enrollment in MA plans is actually projected to reach $29.5 million or 25.5 million members this year. And you can see the arc and trajectory of those members within those plans. It's important to note that this is covered under Medicare Part C, through which beneficiaries can enroll in a private health plan. There are over 3,500 Medicare Advantage plans that are now available nationwide for individual enrollment. That's a 13% increase from 2020 and the largest number of plans that have ever been available. And so, as I mentioned, there's more than 26 million beneficiaries that are currently enrolled in Medicare Advantage. And that's actually 34% of all Medicare beneficiaries today. So, when we think about some of the challenges that Medicare Advantage plans are trying to address, social determinants of health start to come into play here, looking at things like caps and patient satisfaction. These are elements of a successful alternative payment model that will come further into play during our discussion as well. If we look at Medicaid, we can actually see that there has been comprehensive and very intense growth here as well. Since the start of COVID, actually, enrollment in Medicaid and CHIP programs, Children's Health Insurance Programs, grew to 83.2 million in June of last year. That was an increase of 16.8% from February of the previous year, or about an increase of 12 million members within those plans. That growth reflects the downturns in the economy due to the pandemic, as well as provisions in the Families First Coronavirus Response Act that requires states to ensure continuous coverage for those Medicaid enrollees so that they can access that temporary increase in the Medicaid match rate during the public health emergency period. Continuous enrollment has really helped to preserve coverage and halted the Medicaid churn. However, when these requirements end, and they are projected to end relatively soon, states will begin processing redeterminations and renewals, and there's the potential for millions of people to lose coverage if they're no longer eligible or face administrative barriers during the process. So nationwide, it's actually expected that states will need to redetermine the eligibility of over 80 million people that are currently enrolled in Medicaid. Just for context, that is nearly a quarter of the U.S. population. So plans can work with states to leverage their capabilities to improve the customer experience, reduce the number of people losing coverage, and really support those transitions to other forms of coverage for those people that are no longer available or eligible for Medicaid. And so you can see that 69% of Medicaid beneficiaries are actually enrolled in comprehensive Medicaid managed care plans. And what we're starting to see with these Medicaid managed care plans are a variety of different value-based incentives that are occurring within the network that helps them to really manage the risk of their member population. As we continue to talk about the changing healthcare landscape, another important note/context to have is understanding the demographics. And so demand trends are really major drivers of healthcare costs. So we're talking about an aging population and the growing prevalence of chronic conditions. It's estimated between 2010 and 2030, the older population as a share of the total population in the U.S. is projected to jump from 13% to 20%. That will double its share from 1970. The number of workers per Medicare beneficiary has declined from 4.6 during the early years of the program to 3.1 today, and it's projected by the Medicare trustees to fall to 2.3 by 2030. The older population is and will be for some time less diverse racially and ethnically than the total population, and whites, Caucasians will remain a majority of the older population through 2060, whereas they will no longer be a majority of the population above the total population by 2043. As we think about this changing healthcare landscape, it's also important to note the chronic diseases that are affecting this older population. Chronic diseases afflict 1 in 6 Americans. Nothing kills more Americans than heart disease and stroke. There are actually more than 868,000 Americans that die of heart disease or stroke every year. That is actually 1/3 of all deaths. So these diseases take an economic toll as well, costing our healthcare system $214 billion per year and causing $138 billion in lost productivity on the job. Another chronic disease that has been calculated is obesity. It affects 19% of children and 42% of adults. This puts people at risk for chronic diseases such as diabetes, heart disease, and some cancers. Over a quarter of Americans 17 to 24 years of age are too heavy to join the military, and obesity costs the U.S. healthcare system about $147 billion per year. And so when we are thinking about this in the context of alternative payment models, there's actually a quote from AHIP that says over 28 million Americans, which is 44% of Medicare beneficiaries, choose Medicare Advantage plans because they offer better services, better access to care, and better value than original Medicare. This includes nearly half of all racial/ethnic minorities that are eligible for Medicare. And with that, I'm going to turn it over to my colleague, Mary Srinivas.
Thank you, Ryan. I'd like to go through now and talk to everyone a little bit about some of the APMs that have existed in the past. Then I'll move on to what we're currently looking at as APMs in the present, and then some of the APMs that have been projected for the future. So the Center for Medicare and Medicaid Innovation was actually authorized under the ACA back in 2010. And it was tasked with designing and implementing and testing all of these new healthcare payment models to address concerns all about rising costs, quality of care, inefficient healthcare spending, and all of those things that we're continuing to tackle today. In the ensuing decade, CMMI launched over 40 new payment models. They involved more than 18 million patients, 200,000 healthcare providers, and many of those models were in Medicare, and they included accountable care organizations, bundled payment models, and medical home models. So when combined, those three types of models in Medicare were located in all 50 states and the District of Columbia. The Innovation Center tests payment models in Medicaid and CHIP as well as Medicare. And then they also award grants to state agencies, researchers, other organizations for projects to design and implement new payment models with the same kinds of goals as Medicare models, which is improving care and lowering costs. While the focus of the Innovation Center is on Medicare, Medicaid, and CHIP programs, the interventions also include multi-payer alignment models that affect patients with commercial insurance. So it's very important for us to keep in mind with our clients that we might want to partner with them in these multi-payer alignments. So since 2010, the adoption of value-based payment models in the U.S. has actually been pretty slow. At times, it's been a bit arduous. One recent report showed that as of 2020, just a couple of years ago, about 61% of payments were tied to quality or value in some capacity. So that includes pay for performance, shared savings, shared risk, and population-based arrangements. For the remaining almost 40% of payments, that was still strictly fee for service. And while those percentages vary across the different lines of business, Medicare, Medicare Advantage, commercial payers, it does appear to indicate there's an encouraging trend toward increased value-based payment adoption, even though we're not 100% there. Now, I mentioned ACOs and bundled payments in medical homes already. And here on this slide, you see some of the other Innovation Center programs that were tried. Late last year, CMMI released a strategy refresh, and that's because the evidence on many of these Medicare payment delivery system reforms is pretty mixed. While some of the models were meeting and improving quality goals, the actual overall net savings to Medicare stayed pretty modest, with a lot of variation in results between the program models. So after accounting for shared savings and losses, models that required ACOs to be at financial risk for their total spending, like MSSP tracks 2 and 3, did achieve net Medicare savings. However, models with no risk, think like the bonus-only MSSP track 1, that ended up resulting in net Medicare costs. That's pretty unsurprising, as we've seen that downside risk models do overall result in more changed provider group actions. So results from voluntary bundled payment models show that the clinical episode with the most potential for Medicare savings has been the hip and knee replacement bundle. And that saved an average of just over $1,200 per episode, without any notable quality differences from the comparison group. And then most medical home models had lower Medicare spending on covered services, but incurred net cost to Medicare after accounting for some of the care management fees that exist in that model. But the good news is that the quality scores for medical homes were actually similar to matched comparison groups. Now, other than those three, most of the other models didn't result in demonstrated savings. That includes CPC Plus, the comprehensive ESRD model, and both of those ended in 2020. Then there's programs like the oncology care model and the independence at home demonstrations, and those are ongoing today, but currently have no proven savings. So basically, after years of testing a myriad of APMs, data shows that population-focused total cost of care models with downside risk are the ones that are consistently producing savings, while most of the episodic or disease-specific models are not. So that takes us to the models that we are working with at present. So let's talk about some of the new care delivery models to which CMMI gave rise that are currently in action. Now, remember, value-based care revolves around the idea that improving healthcare quality for patients and preventing problems before they begin results in lower costs. Value-based care models stress an integrated team approach where patient information is shared and care is coordinated. So that makes it a lot easier to measure outcomes. For medical homes, we're looking at the integration of primary, specialty, and acute care on a team approach led by the patient's primary care physician. Medical homes share medical records with all of the doctors and anyone else on the care coordination team so that everyone can have easy access to that same patient information. Accountable care organizations were created specifically for Medicare patients. And hospitals, doctors, and other healthcare providers work together to provide the most effective care for the lowest cost possible. ACOs are focused on teamwork, data sharing, with, again, the goal of coordinated care to ensure that patients are getting the right care at the right time while avoiding unnecessary duplication of services and preventing medical errors. Then there's centers of excellence. The term centers of excellence is actually used pretty broadly throughout the healthcare industry. Now, generally a COE offers specialized programs within a healthcare facility that aggregates high concentration of expertise around that service, and all of the related resources are centered on particular medical areas so they can deliver comprehensive interdisciplinary care for that service. The Center of Excellence is a hospital or a healthcare facility where patients continually return to receive primary care or treatment for an acute condition, which is separate from the place where they were originally diagnosed. Those facilities are often epicenters of care provision for large patient populations, and thereby they're an example of all of the best practices within a particular specialty. So as we're shifting to value-based care, aggressive downside risk arrangements should be the goal of every payer, because we just talked about how downside risk is what really works to get a provider group to take action. But it's not just a switch that can be flipped on. Offering a pathway to risk partnerships with providers illustrates the advantages of moving to long-term risk while giving provider organizations time to actually adapt to the new models. The starting point is status quo, historic fee-for-service framework. In this stair-step graphic, as you move left to right, each of these models offers a higher level of financial risk and a higher degree of provider accountability. On the far right of the stair steps are models like full capitation. In capitation payment models, prepayments to physicians or medical groups are given based on predefined services. The compensation is typically calculated based on a range of services provided, the number and risk level of the patient panel, and then the benefit to the physicians of that capitation, beyond even more direct control over their costs, is the cash flow, which is more predictable. and members then have more predictable healthcare costs themselves. That's actually been really beneficial for providers during the COVID pandemic and has allowed groups under these types of contracts to remain financially stable despite many unknowns in their cash flow. So let's move on to talking about what might be coming down the pipe in the future. Late last year, the Innovation Center set a strategic goal for the next decade, and that was to transform the healthcare system into one that achieves equitable outcomes through high quality, affordable, person-centered care. As part of this, there's a commitment to designing models that are inclusive of a variety of providers who care for underserved populations, which will increase Medicare beneficiaries' access to high quality care. Models are organized into 7 categories based on those strategic goals. Those are accountable care, episode-based payment initiatives, primary care transformation, initiatives focused on the Medicaid and CHIP population, initiatives focused on dual Medicare Medicaid enrollees, initiatives to accelerate the development and testing of new payment and service delivery models, and then initiatives to speed the adoption of best practices. Some of the new models that have been recently announced are shown here, and one major model that's currently in the request for application stage that you may have heard about is the ACO REACH model. ACO REACH is a redesign of the global and professional direct contracting model in response to the feedback from the Medicare professionals and administration priorities. So ACO REACH is going to enable CMS to test an ACO model that can inform both ongoing MSSP and additional future payment models. That means they're going to bring into focus 3 key concepts. The first is advancing health equity to bring the benefits of accountable care to underserved communities. ACO REACH in particular will test a payment approach to better support care delivery and coordination for payments in underserved communities, and will require that all model participants develop and implement a health equity plan to measurably reduce health disparities in their populations. The next component is promoting provider leadership and governance. So the ACO REACH model includes policies to ensure that healthcare providers continue to play a primary role in accountable care. That means at least 75% control of each ACO's governing body generally must be held by participating providers or designated representatives. Another goal is protecting beneficiaries and the model with more participant vetting, monitoring, and more transparency. So CMS is asking for additional information on applicants' ownership, leadership, and governing boards so that there will be better visibility into ownership interests and affiliations. That'll ensure that participants' interests align with CMS's vision. Participants can expect upfront screening of applications, monitoring, and more transparency for them into the model's progress during its implementation and before finalization of results. So now that you've heard about a few of the APMs, Ryan is going to talk to you more about adoption of a successful APM and participating in a successful APM.
Thanks, Mary. So before I get started on this section, we're actually going to start with a poll question. And so the question is, are you participating in any of the APMs that we've mentioned or talked about today? Yes or no? And we'll just give you all a couple of minutes to submit your answers before we go on to the next slide and see what the poll results are. All right, I'm going to give it just about 10 more seconds, and then we'll see what our answers are. All right. So 76% of you said yes, and 23% said no. So that's, I think, a really good representation of, looking at the adoption of these alternative payment models and really starting to, move towards risk. Awesome. So when we talk about moving towards risk, one of the things that Mary mentioned is that it's a gradual process. We can't expect it to happen overnight. And so one of the things that, we talk about at Cotiviti with our clients is really this glide path to risk. Fee for service is really the status quo for a lot of people, and it was in the past as well. PCMH was very much a voluntary program that was a lot along that bonus model that Mary mentioned from past APMs that are starting to be retired. So in the past, really what the system did was it incentivized the stakeholders to do more visits, do more procedures, write more scripts. And so, it's really not hard to understand why this movement towards, complete downside risk is much more of a gradual process. Everything within our healthcare system really incentivized that fee-for-service payment model. Our current state today has a couple of different models that are currently active and being worked on. So we have BPCI, which is, again, a voluntary model. We have CCJR, which is a mandatory model. And then we have the ACOs, which are mandatory for shared savings. And so as we look at the current state, the system has been incentivized to meet quality outcomes and reduce cost incrementally. And that's something that makes a lot of sense, right? This is not something that, we can expect to happen overnight, but it is important to start really integrating some of those key measures and metrics when it comes to quality, when it comes to patient satisfaction, when it comes to facility costs, and when it comes to outcomes. And so really, what does the future state look like? The future state has, the next-gen ACO models and a lot of value models that will end up becoming a lot more mandatory as we move into the future. And within this future state, really what the system is going to be doing is incentivizing health plans and providers to keep people healthy and out of the operating room and physician office. So when we look at what are some of the measures that need to make up this future state, and what are some of the measures that are important when it comes to a value-based payment model, some of those KPIs are going to look extremely familiar. Avoidable ED visits is something that's already talked about a lot today. Per procedure costs and complication rates and costs are, again, very familiar to really anyone that's operating within this space today and looking to improve member outcomes. So incorporating these facility metrics is going to continue to be important as we move into the future with those future state APM models. Looking at provider metrics within ACOs, medical groups, and MSOs, looking at elements such as medication adherence, where are generics being prescribed versus brand when it comes to prescription drug coverage, looking at outpatient encounters, and then really looking at member metrics also. So what does patient leakage look like within the network or within the provider health system? What does the member experience look like from a CAHPS perspective? What is the percentage of low-value care that's being delivered to the member within the healthcare system? What's the total cost of care look like within that system? And then really undergirding these three things is that explicit risk and quality. And so we know that risk adjustment and HEDIS are very, very important when it comes to making sure that the outcomes that are being delivered within the network are of high value and high quality. And so making sure that our risk adjustment is accurate, making sure that we are reducing 30-day readmits as much as possible, basing it all upon evidence-based measures and utilizing select quality measures as we move into the future, and make sure that the evaluation at the provider level and at the network level is easy to understand and it's easy to tie to the value that occurs for the member or the patient at the end of the day. So when we look at what does that look like in practice, I think that best practices are very important to show examples for what a formula could look like for value-based APM success. And so when we talk about these alternate payment models, they really must focus on optimizing the shared decision-making tools that exist for both providers and payers. And so again, what we want to do is important on-ramp to value-based care. APM should also help provide insight on the current fee-for-service patterns and understanding the quality, costs, and outcomes that are associated with those. There needs to be flexibility to align to desired high-level goals, such as reducing high per-member costs, improving value, and addressing health equity. And so when we talk about the 360 approach that really needs to occur there, really what we want to do at the end of the day is eliminate patient harm, engage in accountable care and other alternative contracts that help achieve better outcomes at lower costs. We want participation because it helps innovation and testing. And we want to test those new models because it helps better coordinate care for people with multiple chronic conditions. And it also allows for investment in quality infrastructure necessary to improve and engage in collaborative quality improvement and learning networks. So when we talk about Cotiviti, what is Cotiviti's contribution to this APM success? We want to help reduce overpayments, fraud, waste, and abuse. We want to ensure that members are receiving high quality care. We want to ensure that members are being treated appropriately according to their risk profile. We want to ensure that physicians have information that they need to reduce complications and improve outcomes in an episode. And we want to ensure payers and provider organizations have information at their disposal to optimize their interactions between their members and their high-value providers. So if we were to take the example of network intelligence and how it might help address this formula for value-based APM success, the methodology there is really about asking a different question and challenging some of the typical provider practice mindsets. Within network intelligence, we look at and identify unwarranted variation and low-value care within physician practice patterns to help influence member outcomes so that we can make sure that our members and patients are receiving the right care at the right time for the right cost. And really what it comes down to is it's entirely possible to have high quality on a procedure that did not need to occur in the first place, low cost on a drug that didn't need to be prescribed, and a great patient experience on a visit that did not need to occur. And so that might sound all well and good, but what does the actual application of that methodology look like? Well, it's really about measuring value with clinical relevance. And so within network intelligence, we actually have an overall value score that is made up of 4 different domains that have measures and metric trees behind them as well. But the 4 domains behind that overall value score are the major areas in which providers make decisions, and they help mirror the way that a patient flows through the healthcare system. So we have visits, procedures, pharmacies, and referrals. Our visit score measures how quickly visits escalate compared to peers. So just by walking into that physician's office, how likely are you to escalate into a procedure? Once you do escalate into procedure, the procedure score measures how intensely a provider practices medicine compared to their peers. So do they start with conservative care or do they immediately escalate to high intensity? The pharmacy score measures how a provider prescribes medication compared to their peers. So looking at the prescription of opioids versus non, looking at are they prescribing generics where available, looking at maximal medical therapy where available as well. And then the referral score measures the performance and the appropriateness in the provider's value chain compared to their peers. So after the member or the patient leaves that provider, are they more or less likely to receive high value care as they move throughout the healthcare system? And this is important because what we really want to make sure that we're establishing is a common language between our payers and our providers. And so our risk readiness benchmarks apply research and clinical evidence to large public data sets to identify and help understand that practice pattern variation. So we're utilizing open data and open methods in order to generate our scores. We're using over 5 years of the Medicare Part A, B, and D data set to give us a large multi-year normalized data set on over 90% of all physicians. We then go through a process of defining physician specialties and generating peer cohorts because we want to make sure that when physicians see their scores, they recognize themselves in the peer type and peer group that they have been given, and so they feel like their peer comparisons are accurate. We then apply specialty-specific measure sets. These measure sets are, again, those open methods. So this is evidence from academic research, choosing wisely in order to help us assess clinical quality and medical economics. We then apply risk adjustment, and so our measures are risk adjusted based on the provider's patient panel. Because we're using the Medicare data set for our CMS scores, we use Medicare HCC risk adjustment methodologies. And then finally, we create our benchmarks and our scoring tiers. And providers are scored in each measure based on their relative performance within their peer cohorts. And that relative performance is a very key and important part of how we work. We want to make sure that we're not setting any arbitrary benchmarks. The performance of providers will always be in comparison to their own peer group and not any kind of measure or metric that is set by us. It's also important to note that in addition to using the open data, we have the capability to take in client data and generate scores using our methodology off of that client data, which is important as we look at APMs in being able to have up-to-date reporting on relevant data that informs, payment models, bonuses, et cetera. And so what does that look like from really a deployment perspective? Well, we want to make sure that we're aligning to your initiatives. And so that can be network optimization, so enriching those high value networks that you already have, payments to incentivize value, so enhancing reimbursement models, physician performance improvement, helping to change those provider practice patterns, market expansion, so what's the information that you need in order to enter new markets and lines of business, referral optimization, tiered network design, and member transparency and steerage. So really, how do we optimize those interactions with those high-value providers? And I believe Mary is actually going to walk us through an example of one of those tactics that we see here.
Yes, thank you. Yeah, what does it look like in practice for our network intelligence clients? APM success also looks like, as Ryan mentioned, maximizing either member or patient interactions with the efficient, cost-effective, high-quality providers that are designated by a network intelligence score of a 1, the high-value providers. So one of our clients, who was a regional Blues plan, had consistently been one of the leading payers in the U.S. driving transition toward value-based care. They serve nearly 4 million members across the state's 100 or so counties. And that plan knows, as do we all, that consumers are spending a steadily rising portion of their income on healthcare, which demands a greater focus on increasing value and decreasing price, where there might be a lower value and higher price currently existing within the network. So when a large employer group reached out to that plan several years ago to help motivate its employees to use high-quality providers, the plan took action and implemented a specialist designation program that differentiates specialty practices based on quality and cost. and also using our network intelligence score to provide an efficiency score that gives this comprehensive evaluation of provider alignment that Ryan described, using visits, procedures, pharmacy, referral. They created a designation program that differentiates the providers into tiers based on those different metrics. And then they looked at the tiering solution using providers who are scored by the network intelligence scores, and directed members toward the green dot high value providers. So as more members interacted with these high value providers, the tiering solution then resulted in much higher value and lower price network for our client. The tiering solution resulted in 3% reduction in network spend and led to the plan having more than 50% of their membership seeing specialty providers in value-based care type arrangements over the course of 1 year. So that's just a little look into how we enact our network scores with our clients to really drive success in being able to deploy value-based care arrangements and alternative models. So I wanted to thank everyone for listening in today. Hopefully you learned that alternative payment models have a long and rich history. It's been over a decade now that we've started trying to move away from fee-for-service. And now we've talked about the APMs that are existing today and those that are under consideration for the future, and how we at Cotiviti may be able to help you recognize the benefit of participating and understanding the key success factors in those APMs.
Thank you so much, Ryan and Mary. We're now going to begin answering some of the questions that have been submitted during today's presentation. As a reminder, you can definitely still submit questions through the Q&A pane on your panel. We have a first question. Are providers typically accepting of the scoring methodology?
So yes, as Ryan described, our methodology is based on open methods and open data. And because we are not a black box methodology, we find that network providers are very accepting of the scores once we explain to them the methodology and where we're coming from. They see themselves reflected in our peer typing, and because we're using publicly available claims data, they understand exactly how those scores are created and what they can do to improve them.
Thank you. We had a somewhat similar, or maybe a follow-up question to that one. Can you share anything about suggestions for training the providers to understand the value behind sharing some of the risk?
Yeah, absolutely. So, I think when it comes to training providers to understand value behind sharing risk, there has to be a couple of different elements that come in line. One, there needs to be an alignment around incentives. So this is really where the alternative payment models are important. If providers are not aware of what the incentives are for the alternative payment model that they're participating in, then it's really going to be an uphill battle. And so knowing what the incentives are that exist, and then explaining the methodology behind the scoring and how that scoring actually influences those incentives is really important to making sure that the providers understand the value behind sharing risk. I think the other part to that is making sure that demonstrated outcomes from success are important to share with the provider, understanding what success looks like and how it affects the patient at the end of the day.
Thank you. Do you have any, maybe this one is for you also, Ryan, do you have any examples of clients who have been successful in their efforts to move more providers to share risk?
Yes, we do have examples of clients that have been quite successful. We have a provider client that we work with that actually evaluated some of the unwarranted variation that was occurring within their current health system. What they found was that there was quite a lot of nuke med testing that was going on. They were looking at entering into shared risk models as part of cardiology within this particular healthcare system. And so they actually addressed to the tune of about a reduction of $600,000 in costs due to nuke med testing that led them to join that APM and have a high predictor of success. So yes.
Great, thank you. And for either one of you, I think, what do you think has been the barrier for payers offering more APMs?
A couple of barriers, I think, are the performance target setting. So that involves understanding your provider's performance to begin with. And that's something that, Cotiviti can help with is understanding the landscape of your provider's performance as it exists today. And so then you can set performance targets that are not unduly burdensome to physicians and are achievable and make it worth their while to be in an APM. So really being able to evaluate them in a transparent way and set targets for them within the APM that are achievable while they're still being able to take on downside risk.
I think there's also an element of a, first mover that exists as well when it comes to payers offering more APMs. No one wants to be the first to dip their toe into the market and cause all of the abrasion with their network. And so it becomes a lot easier to, reach more people and hit that provider, those provider networks and offer more APMs once it's already been done within a region. And so I think that's also why you can see that a lot of APMs tend to be localized within certain regions. We can see a large amount occurring on the West Coast where, capitated models have been the norm for a very long time. Whereas in some other regions of the country and rural regions of the country, everyone is just starting to catch up.